as you all know, obstructive sleep apnea is not just a condition. It's a condition that is associated with a lot of comorbidities. Some of them actually have cause-effect association with this condition. Some of them just an association. But when a patient comes to us, they don't come just with a diagnosis of obstructive sleep apnea. They come with a potpourri of symptoms, which we have to basically sit and decipher and just to improve the outcome of these patients. And the whole idea is to sort of improve the outcome of obstructive sleep apnea. And this is just not a one-man show. The idea of the webinar is to talk and sort of convey the message that management of obstructive sleep apnea cannot be managed by one single specialty. It is something that involves a cohesive network of different specialties to bring out the best in terms of treatment. And with that particular idea in mind, we sort of brought out this particular webinar, which is a multi-speciality webinar. And I sincerely thank ResMed for giving us such a wonderful platform so that we can all discuss these problems that come and that we face from these patients of obstructive sleep apnea with associated comorbidities. And that is what we're going to focus in this particular webinar. Without further ado, let me request Dr. Rahul Modi to start his presentation.
Hi, everyone. Good evening. Many thanks for the kind invite to the ResMed team and Dr. Srinivas for organizing this wonderful event. I'll just start sharing my screen. Just a second. So I hope my slides are visible. Right.
Yeah, they are visible.
Yes, thank you. So good evening, everybody. Thank you so much for joining us. I hope with the pandemic waning down and normalcy returning hopefully sooner than later, we will get back to our routine practices. And today's talk is essentially just about how my approach as an ENT doctor, as an ENT surgeon has changed in managing OSA, understanding OSA. So if one goes by the traditional descriptions of OSA, it was classically the Pickwickian syndrome described by Charles Dickens in his famous book, The Posthumous Papers of Pickwick Club, where essentially Joe the fat boy used to have excessive daytime sleepiness, was an obese, snoring child. And that is where the initial descriptions and the classical descriptions of sleep apnea came from. And as our understanding of sleep apnea improved over the decades, we understood that it's truly a multidisciplinary in its presentation and requires a multidisciplinary approach in its management. But essentially, the impact of sleep apnea on our health is through two pathophysiological entities. One is the fragmented sleep that occurs because of the repeated obstructions and the intermittent hypoxemia that leads to all the cardio and the metabolic side effects of sleep apnea. Now, when we look at the treatment paradigm, when we are treating sleep apnea, the thought process behind is the classical Starling resistor concept, where we have the rigid tube as the nose at one end, a rigid tube as the trachea on another end, and a collapsible oropharyngeal segment in the middle, which can open and shut and thus leading to snoring. And hence CPAP works so well, right? Because the CPAP is just another pneumatic splint, which will essentially blow air and prevent the tongue and the palate from collapsing and thus keeping the airway open. However, the challenges that we face as a treating physician is CPAP doesn't give us very high compliance rate. Studies have shown long-term compliance rate to be in the range of 40 to 50%. So still there is a big patient population that needs addressal. Now, when we look at the upper airway really is a complex region, which is divided into the nasal region, the palatal region, the tongue region, and the laryngeal regions. And once one looks at what all things that can go wrong in a patient with sleep apnea, it's really a long list of things. It's including the craniofacial retrognathia to the pharyngeal changes, the dental changes, and of course the nasal changes. And hoping that CPAP would really ameliorate all of this in all of our patients and the same therapy would work, regardless of where the problem is asking for too much. There's a very interesting paper where they said that even though the obstruction may be at one spot, that is our nasal cavity, the collapse may occur at another spot. So what you have is you have a collapsing anatomical structure, which is essentially the oropharyngeal, whereas the primary site of flow limitation is occurring at the nasal cavity. So when we are looking at sleep apnea, we need to not only address this part of the airway, we have to think about how things are happening higher up in the nasal cavity. So a simple message that I want to give to all my colleagues here who are into the practice of treating sleep apnea is please do not ignore the nose. The nose is a very important part of the examination, and things like a nasal valve collapse, a gross septal deviation can interfere with the care that we provide to our patients. And one can assess the airway very simply if you're evaluating the nasal cavity. A simple headlight examination of the nasal cavity and the nasal valve can be done for the patient. And if you're suspecting something severe, a simple fiber optic exam done in the clinic in the same setup takes hardly 10 to 15 minutes to evaluate the nasopharyngeal and the oropharyngeal area through a fiber optic scope. What we normally miss out though is examining the nasal floor. A high arch palate is a very common entity in patients who are mouth breathers, and it also implies a narrow nasal floor because the nasal floor forms a roof of the mouth. Hence, a high arch palate will lead to a narrow nasal floor, and this is what we call as a loss of complaints. And these are what adult mouth breathers are, and these are the patients who will find it very difficult to wear a nasal mask. These are the patients who may perhaps tolerate an oronasal mask, or when you are thinking about a nasal mask, you will have to think about giving them a chin strap along with this. So a simple score that anybody can use in the OPD is the nose score, where we can ask these set of questions whether the patient has had any of these symptoms in the last month or so, that is nasal congestion, nasal obstruction, trouble breathing through the nose, or trouble sleeping, and does they feel that they get suffocated, they are not able to get enough air through the nose during exercise or any exertion. Once we add up the score, the maximum being 20, one can multiply that by 5, and the score that comes out is anywhere between 5 to 100. Now, if somebody is having a severe and an extreme kind of a nose score, please get that nose evaluated through an ENT surgeon, and we need to realize that this will interfere with any treatment selection that we do. So what happens when we start treating the nasal cavity? So simple nasal surgery such as a septoplasty or a turbinoplasty, and a systematic review analyzed that about 45% of patients had nasal obstruction and they were not tolerating CPAP that well. Once a nasal surgery was done to relieve the nasal obstruction, CPAP pressure dropped by almost 2 centimeters. And almost 89% of patients who were not using CPAP earlier started using CPAP now. So again, examination of the nasal cavity, addressing the problem, improve the outcome. So that was lesson number 1 for me. Lesson number 2, and this is a paper, Dr. Kishore is also a part of it, very nicely done. Even when we are doing multi-level surgeries for the upper airway, the nose patients not only did better in the AHI manner, but also had improvement in the sleepiness score. So adding nasal treatment improved our upper airway surgery outcomes too. And also with the most, an upcoming popular option that of an oral appliance, poor nose scores. So oral appliance works by pulling forward the oropharyngeal airway and opening up the oropharyngeal airway, and poor outcomes are seen in patients with high nasal resistance, which is common sense essentially. So one should consider combination therapy. The second learning was that of atypical presentations. Now, a common myth with OSA is they are sleepy and obese individuals. And what studies have shown us, this is a very nice paper by Danny Eckert's group, is that more than half the population that was referred to their sleep clinic were not obese. So it is very important that we don't just try to label patients and think of these patients as obese patients, but even non-obese patients have a high amount or high incidence of sleep apnea, and non-obese patients tend to not respond that well to traditional therapies. If one looks at the sleepiness aspect, 65 articles, this is a very nice systematic analysis over a long period of time. And what we found is in this paper is only about 46% of patients with moderate to severe sleep apnea had excessive daytime sleepiness. So although these patients, even without excessive daytime sleepiness, had the same level of cardiovascular comorbidities. So even though the patient is non-sleepy, non-obese, they are still at risk of a lot of side effects from sleep apnea. Hence, even though they may not have the classical presentation, one must not miss out these patients. A very nice approach as to how the upper airway works really. The upper airway is a very dynamic structure. What we are treating currently with our traditional methods are just the mechanical properties. However, we are missing out on the other factors which influence the airway shape, including the arousal threshold, the respiratory control, and also the muscles that actually guard the airway, that guard the oropharyngeal airway. So it is important to treat the non-anatomical factors also. So what are the non-anatomical factors? Now, typically when we see the factors affecting upper airway, one is the anatomy, that is treating the collapsible tongue. However, about 2/3 of the patients will have significant non-anatomical tendencies. They may have a low arousal threshold, they may have a high loop gain, they may have a poor muscle responsiveness. And this is what we should target when we are treating, and keep in mind when we are planning treatment strategies for our patients. So think about a person with insomnia. You would typically think of this person having a low arousal threshold, whereas a patient with OSA is considered typically to have a very high arousal threshold. Now, there is a significant subset which has this overlap. So studies have shown us almost 30% patients with insomnia may have coexistent OSA symptoms, and about 40% patients of OSA may have insomnia-like symptoms. They have called it, the literature labels it at COMISA as comorbid insomnia and sleep apnea. And these are the patients who suffer the maximum. They have greater impairment of the daytime functioning and quality of life compared to those with either insomnia or OSA alone. And these guys are the ones who will naturally have poor CPAP adherence, and they actually need initial CBTI and insomnia management along with treatment of sleep apnea. So one needs to keep this kind of presentation in mind. Treating the upper airway muscle tone along with treating the anatomical factors has also shown encouraging results. Just by providing myofunctional therapy, one can improve AHI by almost 50%, improve the sleepiness significantly, improve the oximetry parameters also. So this breaks down a second myth that is commonly there, that once one get the OSA severity through the sleep study, one can do the treatment selection. Mild sleep apnea can be thought of being treated with a single modality of the oral appliance. Moderate sleep apnea can consider surgery, and severe can go for CPAP. Whereas the treatment essentially depends upon the anatomical and the non-anatomical factors, which the sleep study is not diagnosing it for me. So rather than a single modality, one should think about the multimodality along with the traditional treatment modalities of oral appliance, CPAP, and surgery. One must think about adjuvant weight loss and positional, but also about newer therapies like use of myofunctional therapy or drugs which are coming up. And this starts with having a conversation with the patient, knowing what are their symptoms, what kind of a presentation do you think he's presenting with, what is the trouble that he's asking treatment for, and then planning the treatment likewise. So the take-home message for me from my experience was OSA can have a varied presentation, and awareness of all these presentations is key. Examination of the upper airway is an essential part of evaluation, especially if a person is having high nose scores. And one needs to personalize the management strategy depending upon what we perceive to be the obstruction levels and the other factors at play. And it is really a chronic disease that requires a long-term and multidisciplinary management, so that we don't end up having a one-size-fits-all kind of a approach and have a personalized made-to-measure approach. Thank you so much.
Thank you very much, Rahul, for a beautiful presentation. And I think it sort of touches each corner in terms of managing obstructive sleep apnea. What I will do now is we'll start the panel discussion. And before we start the case discussions, I would like to share with the audience and also the panel the different ways in which OSA is associated in form of comorbidities and how it can present to us. As Dr. Rahul was saying, that it doesn't present only in a particular way. It can present in many ways. So let me just share my screen here. Can you see my screen?
Yes, sir, we can see.
It's visible, sir.
Yeah. So this is something that you're going to see a lot, and I'm sure everybody sort of plays this particular slide when it comes to obstructive sleep apnea management. So dear colleagues, all of you would definitely agree that we have clearly moved away from having a nail and a hammer approach, wherein a surgeon's going to hit every particular patient of obstructive sleep apnea with surgery. A sleep physician and a pulmonologist is going to hit every patient with PAP therapy. We've definitely moved away from that. And we are now talking about personalization in the treatment and management of obstructive sleep apnea. Now, as Rahul just said, it's actually a cohesive management when it comes to obstructive sleep apnea. Once obstructive sleep apnea has been diagnosed, you start a journey with this patient. At some point in this journey, these patients will require any of these kind of treatment modalities. It may not be that the patient will get well completely with PAP, or it will get completely better with an oral appliance, or just doing a myofunctional therapy will not control his problem. And as we now know, just weight management and reducing weight will not solve all problems. So when we start this journey, we need to understand that these patients require a lot of hand-holding and need to give in each modality of treatment basically depending upon at what part of the journey this patient is in. Now, coming to the basic thing this whole webinar is based on, sleep apnea treatment and consideration in patients with comorbidities. Comorbid sleep, as we now call it, medical and psychiatric disorders can significantly affect the use of PAP. And why do we keep going back to PAP? Because it is a gold standard treatment. And this needs to work for our patients to get better. And multiple reports in literature document an overall low compliance with PAP despite its efficacy in comorbid sleep. And hence, a team approach is required to treat these patients. So let's talk about COMISA that Rahul was touching upon. COMISA, as it's called, that is comorbid OSA and insomnia, started appearing right in the 1970s, right about the same time when OSA was also becoming popular by Gillimanol. And these are certain numbers to discuss with you. if you really look at the prevalence of insomnia in patients with OSA ranging from about 42 to 55%. Now, why is it so important? Because insomnia further worsens PAP tolerance. And as it's been said, that CBTI is highly effective modality of treatment focusing on patients' maladaptive beliefs and altering the conditioned insomnia response. But it is of very significant and clinical importance to learn whether patients with OSA also have insomnia before the treatment. So what I would like to ask you, and we'll start off with Dr. Deepti, is that because Dr. Nimish, you, all of us come from different backgrounds. So I would like to sort of start with you, ma'am, that in your practice, this is a number from literature. How much of COMISA do you actually see in your practice? And then I would go to Dr. Nimish, and I would like to understand his experience with COMISA.
So, as far as my practice is concerned, more than a practice, I would like to quote my own study.
Okay,
so I have been credited with the only study done from India on sleep apnea and insomnia, COMISA, what you call it as, recently published in Indian Journal of Sleep Medicine. I just that's what we call it.
Wonderful.
So we had about 15%, 15.5% patient falling into the criteria of COMISA. Now, there are different guidelines for diagnosing insomnia. And these guidelines vary from, time to time. So based on which guideline you are using, the prevalence varies. But all said and done, it is a difficult problem, and one has to make sure that that is being addressed some way or the other, and the patients are managed, because otherwise the patient will simply not take treatment for obstructive sleep apnea. And normally, what we do is we simply prescribe them with some kind of sedatives. So one has to be very careful in just, prescribing a sedative. If everything else has been ruled out, zolpidem is, or S-zopiclone is something which we use commonly. But yes, it is one thing which we need to ask, and there are 3 simple questions. I don't know if I'm allowed, how much time I'm allowed, but 3 simple questions that I always include in my proforma for sleep. I have my own proforma for sleep, and these 3 simples are difficulty in falling asleep, early morning awakening, and difficulty in going back to sleep once awakened. So these 3 simples, when you ask along with the, of course, EDS criteria, it does satisfy your insomnia guidelines, and it is common. Though you have quoted 42, but many literature figures have also said 15 to 20%. So it's like about that. Some studies have said about 40%. So yes, it is something which is very important, and it's a part of all sleep history that one must take.
So as you correctly said, ma'am, I think the numbers basically depend on what metric you're using to sort of measure this.
Absolutely.
But the questions that you were asking the patients, ma'am, that I wanted to ask you, because it is maintenance insomnia which is more common with OSA than initiation insomnia.
Absolutely. Yes.
So this is what I wanted to ask you also is that even though literature sort of talks about cognitive behavior disorder, cognitive behavior therapy for CBTI, but how practical is it in the Indian setting for our population?
It is very, first of all, people don't come out of insomnia. Means people don't reveal that they have insomnia. People try to hide if they have insomnia. They kind of, put it under the carpet unless you actually directly, pointedly ask them the question. So if you have a patient of sleep apnea and you do ask them, you do get to know that how common it is. It is something which is which should be talking about. And that CBT that you were saying, yeah. I myself was trying to put my mother-in-law for CBT. She did have insomnia, and it gets very difficult to find a practitioner who actually practices CBT. So because the problem is not identified, even remedial measures are not really very well in place as much as they should be.
So I would like to now ask Dr. Nimish's inputs onto this particular problem. What do you see? Because you come from a completely corporate setup, right, Dr. Nimish?
Correct, that's right.
So I would like your take on this.
So I'll be honest with you, I don't see too much of insomnia in the area that I practice, because most of the either primary patients or referrals that come to me are mainly, either post-stroke, because I work in a big neuro setup. So I see a lot of pure comorbid OSAs. But coming to the question of CBT, I completely agree with you. I think there's a big void which we need to fill up, because we don't have trained psychiatrists and psychologists who actually are interested in CBTI and who actually practice it. At least in the area that I practice, I have none. Again, so I think to answer the question of percentages, so I take a comprehensive sleep history, which all of us do, I'm sure. And I insist on my patients who I suspect insomnia to keep a 7-day sleep diary and a daily routine as well. That really helps me, because again, actigraphy is not something that is commonly available here. And again, cost implications also always limit us into what we can do. So to answer the question in short, I don't see too much of insomnia, but in the few occasions that we do, again, sleep diary. In terms of treatment, so Z drugs, as Dr. Goti quite rightly said, are the safest. I use a lot of melatonin as well in my practice, and Ramiltion is the other one, which actually has shown good results. I've used it in a few patients, but again, drug availability is a big issue locally.
Dr. Datta? Dr. Dipankar?
Yes.
Yeah, I want your inputs on this particular problem. And how much do you see in your practice?
Not very frequently, but not that I don't get. I get a couple of insomnia patients, not frank insomnia. I find insomnia concurrent with OSA, that is COMISA. Correct. Because on details history, I start my examination, as Rahul aptly said and what you said, because as soon as a OSA patient come up to our chamber, be it a direct patient or referral patient, definitely we take it for sure. We have to take from the scratch. So thorough sleep history is what I start my discussion with. So from that point of view, after details examination in many patients, maybe as per the percentage, at least 15 to 20% of the patients for last 1 and 2 years, particularly during this pandemic situation, they are suffering from insomnia, and I am getting maybe this lockdown, pandemic, homestay, total disorder of the work schedule, OSA concurrent with insomnia has increased in my practice. So I treat these OSA patients, and I take help of my neuropsychiatrist friend. I have fortunately a guy here in Calcutta to whom I send for this CBTI. He does CBTI. But
wonderful. Lucky you.
But adherence is a big issue, because the one challenge is not getting a proper physician to do CBTI. But even more challenge from their point of view, what his feedback is, they don't adhere. Just like any behavioral therapy, they need at least 10 to 12 sessions. These patients actually drop out after 3 or 4 sessions.
Thank you. I think that's a very good point. So that the problem is just not from having the resources to give CBTI. The problem is from the receiving end as well.
Exactly.
We'll quickly shift to rapid eye movement behavior disorder, and I'm not going to spend too much time onto this. And again, I'll start from Dr. Goti again. So ma'am, in your practice, I'm sure you do see this particular behavior disorder, and it has been shown that people with this kind of a disorder generally have their masks taken out involuntarily. Is that what you've seen in your practice, or have you seen a different picture?
So whatever RBD I have seen, they generally they are on antipsychotic drug, or they have a Parkinsonism, early Parkinsonism kind of a,
Yes, ma'am. Perfect.
yeah. So a kind of a, already a patient is going into Parkinsonism in early phase, or they are on drug. But classically, OSA, obstructive sleep apnea, with this, I have not seen who remove the mask. So specifically that you were describing, that they remove the mask because they have RBD. But I can imagine if they have RBD, then it is very much possible that they would remove the mask because they don't know what they are doing during their rapid REM eye movement disorder. But yes, I have seen RBD with obstructive sleep apnea, and it gets very tough to distinguish what is causing what, and
Exactly.
they are a little difficult to manage patients than just simply obstructive sleep apnea. Yes, RBD is like 1 to 2% of my practice.
Fair enough. So I think the next question is, of course, something that we normally see, that is periodic limb movements. And so quickly, I would like to ask Dr. Rahul. Rahul, can you hear me? Rahul?
Right, sir.
Yeah. So just a word quickly before we go further about periodic limb movements and RLS in your practice.
Typically, not very common, but definitely literature mentions it to be a common entity, especially in the elderly population. So normally, the way I would get a referral for an RLS patient is actually from a neurologist who's not getting sufficient response in terms of the refreshingness of the sleep. If the patient is still complaining of persistent EDS after sufficient control of RLS with medications, and that is when we would get involved, but not very frequently. The most frequent actually that we see is actually CUMISA only in practice. In terms of that's very underdiagnosed, I feel, when we see a patient with sleep apnea.
So because I think, again, these limb movement disorders actually make cause, so we really don't know whether if this is what is causing the EDS, or it is the sleep fragmentation by the respiration which is causing the so ma'am, in your practice, Dr. Gupta, what do you how do you decipher this EDS that comes with the limb movements, and also if it's a mixed bag? How do you really decipher this EDS for the patients?
So before actually I answer your question, I would like to share something about RLS. It is one of the most easily diagnosable disease, and it is least diagnosed. Even though it can be diagnosed easily, nobody bothers to check on the patient. And it is diagnosed with the help of 4 criteria, that is urge. Urge to move the leg, Coca-Cola-like sensation in the leg. It gets aggravated by rest, gets relieved on activity, and has evening or night preponderance or evening or night predominance. Now, these 4 symptoms, like insomnia, I have included even RLS in my proforma. So my proforma carries both RLS history and this, and you won't believe it's 15% of the patient, and it's recorded abroad also. It's recorded everywhere. In fact, in COPD patient, we get nearly about 30 to 50% of patients with RLS. It's extremely common. Because we don't look out for it, we don't get it. And I've had patients where, to now answer your question, I've had patients wherein I thought this is obstructive sleep apnea. The patient actually did have snoring, patient actually had diabetes, patients actually were obese. But then when I did their sleep studies, there were no obstructive sleep apnea. And then I was wondering, and that led me to RLS, PLSMS, and depth of that. And I realized quite a few of our patients do have. So how do I decipher that? Now, simple thing is that when you have OSA, secondary RLS, secondary PLMS is known, very common. So one needs to treat that. But when you have RLS and PLMS together, now that is something very difficult. And best thing is to do iron studies. So if you're really suspecting RLS, if you're really patient, actually tell you that I can't sleep because I feel like moving my leg. I can't sleep because there is so much of heaviness in my leg, and when I move, it becomes okay. And if you have detected that they have RLS, it's best to do iron studies. If you have iron below 50 or 75, treat RLS, because I've had 9% of my patients who have obstructive sleep apnea primary and RLS also, and treating both only has led me to the final satisfaction of treatment of these EDS. So EDS sometimes is overlapping, cannot be. One needs to be thoroughly into the history and treat both if the need be. So that's what
I would completely agree that satisfaction thing, because my father had the same thing, man. OSA with RLS, and once you treat them, I think they're extremely happy, and otherwise he was, I mean, screaming out in discomfort. So I think this is a very, very prevalent problem that actually needs attention and given importance to. So a little bit of TEXA. Now, one needs to understand, especially our ENT colleagues, we need to understand that treatment emergent central sleep apnea is not only for PAP therapy. It can also happen after dental appliance therapy, after surgery, and even after tracheostomy. And I mean, in the ENT community, we would always talk about TEXA as, okay, this happens only with PAP therapy. No, it doesn't. It can happen with any kind of management. And one needs to also understand that most of the times CPAP, if given for a period of time, does treat it, but not always. And otolaryngologists consulted for a surgical evaluation, and this is something that we as ENTs need to understand. So otolaryngologists consulted for surgical evaluation of patients with sleep apnea must know whether TEXA was noted on a previous PAP titration. Because if it was not noted and if there is no improvement, most probably whatever you do, even if you do a tracheostomy, it probably may not get better unless you get into different kinds of PAP therapies, and that is the adaptive serial ventilation and things like that. I would like to bring in Dr. Nimish about TEXA and his inputs on this.
Yeah. So I completely agree with you. I think it's very important to, when you do your PAP titration, to see what your scores on the CSAs are. Because quite often, patients who have predominant CSAs, you need to find the cause for it. And secondly, if it's not treated with PAP therapy, if you see all the evidence behind how to treat central apneas, there is none. So there's a lot of debate which goes on that, autoset CPAPs are good enough. Some people say bilevels are good enough, but quite often it does tend to reduce your compliance on PAP therapy as well. So definitely first identify the cause as to why the patient may have central sleep apnea. And once you've ascertained and ruled out any physiological causes which can be corrected, always do a PAP titration and see whether there was CSA, and probably over a period of time repeat the sleep study to see how the CSAs are working. And if not, I've had a few patients who I have put on ASVs and have actually done very well. These patients are the ones who are typically, relentless, excessive daytime somnolence, comorbid patients, and also failure to comply with PAP therapy, whether it's bilevel or it's CPAP.
Dr. Goti, your takes on this.
Yeah. So as far as this treatment emergent sleep apnea is concerned, as literature suggests, and as we all see, most of it subsides on its own, most of it. And by and large, it is due to cardiac failure, or it was something which was, patient had what is called as Herring-Brewer reflex. So because of that, the patient repeatedly had central sleep apnea, but that was not picked up. And over a period of time, because you keep giving CPAP, it improves. Now, if it is because of cardiac failure, sometimes cardiac failure do respond to an extent, with CPAP itself. So that's how both these reasons, cerebral reflex and because the patients are having underlying cardiac problem, they do respond to your CPAP, normal CPAP.
So,
Now,
ma'am, how long would you want to wait
3 months
before you decide that, this is not working for me?
3 months, 3 months, as the literature says, and as the practices say, whatever the guidelines say, they say at least wait for 3 months before you embark on therapy, because both these SERV-HF and CANPAP trial, both kind of adaptive servo ventilator, especially has a black box warning, especially in US. So if you are in US, you can't prescribe the adaptive servo ventilator. However, there are newer modes coming, and however, if you have documented that adaptive servo ventilator does work in the lab in these patients after 3 months of CPAP therapy, then one can prescribe and go ahead with adaptive servo ventilator. So that's my take on that.
Sure. Then I think we will go to wherein I would request Dr. Vijay to come in. Of course, CSA and CSB, they're brothers. So, and everybody would agree that patients with heart conditions such as congestive cardiac failure and rhythm disorders are those the one that present this way. And Dr. Vijay, in your practice, because you are in a high volume center with a lot of cardiac work going on, and you're an electrophysiologist yourself. So can you just give us a few words about this coexisting CSA and CSB?
Yes, sir. So thank you, sir. First of all, thank you for inviting me to be part of this panel discussion. So, I mean, in contrary to all the other panelists who are actively involved in treating patients with sleep apnea, we are in a position where we kind of pick up patients, screen patients from our outpatients, and then send them for a sleep apnea evaluation and then treat them. So regarding this cardiac comorbidity, sir, like it is, I mean, well known that many of the factors like hypertension, pulmonary hypertension, especially arrhythmias like AF and BPCs, and also heart failure to a large extent is associated. Even among cardiologists, there is a tendency for us to overlook OSA to be linked to one of the cardiac conditions. But some of the conditions, as you said, myself being in an electrophysiology unit, there are some conditions that we have a very low threshold to screen for an OSA. One of them is like a resistant hypertension. So suppose a patient comes with repeated blood pressures measured 160, 170, and is already on multiple drugs, 3 or 4 drugs, then these are some of the patients whom we have a very low threshold to screen for OSA. That is one subset of patients. And the second subset of patients where we are extremely cautious and we would like to get OSA ruled out is patients with atrial fibrillation. And because not only for medical therapy, even while we offer catheter ablation, like either in the form of RF or cryoablation that has come recently, the outcomes are or the recurrence rates of AF are considerably higher if the concomitant OSA is not treated. So while treating patients with AF, we again have a very low threshold to screen for OSA. And another important thing that we have frequently encountered in our clinical practice is patients with frequent VPCs. And this is something that probably even for me, it was a very learning point after coming into the electrophysiology unit, where we see patients who have been referred for ablation for frequent VPCs. We have picked up patients with OSA, and just subjecting them to a CPAP therapy, their VPC burden considerably came down. And I can quote the n number of patients in whom they were referred for an ablation, and just treatment of OSA and some medical therapy was all that was needed to make them free of symptoms. So I guess these are, and another subset of people whom we have again low threshold is patients presenting with diastolic dysfunction, or the HF patients, where again the benefit and the symptomatic relief is considerably good. So these are some of the subsets, like one is resistant hypertension, second is patients with AF, and patients with frequent VPCs in spite of having a normal LV function, and again patients with diastolic dysfunction. So these are the subset of patients where we find that OSA is significantly associated, and effectively treating them again leads to better outcomes, especially symptom relief. So this is what we have observed in our practice.
Wonderful. I think you have beautifully put it in a nutshell, Dr. Vijay. Thank you very much. That again brings me back to, I think, the ball into the pulmonology. So it has been shown that the presence of high loop gain is what has been theorized to be the mechanism in these patients. Ma'am, what is the treatment modality for these patients, that is CSA with CSB?
So high loop gain itself is a little difficult to treat thing. It depends on what you're dealing with. So if one is dealing with congestive heart failure, simple thing is, of course, treat congestive heart failure, possibly that it will subside. But there are many chances that it may not subside. And
Correct.
if you treat them with a treatment of cardiac failure, if it doesn't subside, then there are multiple therapies, which includes CPAP, which includes oxygen therapy, which includes a patient to be given a CO2 or increase in the dead space ventilation. So, attach a kind of a tube in front of the CPAP or something like that. So basically increase the dead space ventilation. And these patients have, of course, adaptive servo ventilator is another one which can be tried. BiPAP is something which should be avoided as far as possible. CPAP per se will improve even cardiac failure. CPAP will improve a central sleep apnea. So I just have a very nice patient to share with, and it's a very classical one. If you have time, can I share this?
Go ahead, ma'am.
Very quickly. This patient had MI, got operated within 15 days of MI. Post-operative, the relative came huffing and puffing, and he said that I'm awake the whole night, watching him helplessly. He just has apnea. He's unable to breathe. He's not breathing in the night. And what do? I don't know. And the patient was referred to us, of course. We did sleep study, his central sleep apnea 45. 3 months after the, his cardiac surgery, healed and whatever, he still had central sleep apnea to a lesser extent. What I'm trying to point out is the central sleep apnea can not necessarily be in form of change stroke breathing. It may be just a central sleep apnea without change stroke breathing, especially in cardiac failure. And it can aggravate with cardiac surgeries too. So all of us know very commonly on cardiac failure, but very few of us know that even post-surgery, they do have aggravation of central sleep apnea. So my take on this is, as far as possible, treat with CPAP therapy, treat the underlying disease, oxygen if at all, and increase in the dead space ventilation. Sometimes even acetazolamide works. So acetazolamide is known to work in some of the patients. Yes, that's my.
Thank you, ma'am. I think we'll take to the next one. So I would like to now brush on some psychiatric comorbidities. And this is something that all of us definitely agree on, that there is a huge comorbid depression which is associated with OSA. And if you look at these numbers, again, they're all over the room, like from 20% to 63%. Like insomnia, because this is a very kind of a subjective way of measuring things, it depends on what scale you use to sort of score the depression. So it can be anywhere between 20 to 60%. And again, numerous studies show that effective treatment of OSA can improve depression symptoms through use of PAP therapy, and that's a given. But despite the balance of evidence showing a positive effect of PAP on depression, there is poor adherence to PAP. And I think that also is a lot of it coming from the patient's perspective. I mean, they sort of feel that, you know, they're sort of married to this particular machine or whatever. They're very bad. And I'm sure all of our patients sort of come with depression, both from a pulmonology side or from the ENT side. And depressed patients tend to be more sensitive to perceived impairments and maybe less likely to provide improvement, especially the subjective symptoms like EDS and fatigue. No matter what you do to them, they completely come back to you. If you look at their compliance reports, there'll be great numbers. But again, if you have done a surgery, it will look very good. The post-op PSG looks great, but they will still come back to you and say, I'm still unhappy. And this is a huge percentage of population if you're really looking at anywhere between 20 to 60%. So I would like to start from Dr. Rahul. And if you remember, we've had a case that I discussed with you. This is a particular police officer. And
yes.
I would like to your inputs on this in your patient population.
So, yes, and actually, I mean, coming to the question of surgery, I'm a little bit of a reluctant surgeon when it comes to sleep apnea surgery. I actually don't like to rush into and getting the expectations in place because, you know, sleep apnea is such a, I would say, unpredictable when we assess in terms of we don't have good correlation between the severity and the excessive daytime symptoms. We don't have correlation between EDS and the AHI and many other symptoms. So I look at why the patient is coming to me and why the treatment is required. If it is because his wife is unhappy because he's snoring too much, or, you know, he's really not feeling well, and only if CPAP is able to reverse the excessive daytime sleepiness completely, can one think about, you know, in a person with a favorable anatomy to think about surgery. If the CPAP, if the patient is having persistent EDS, even after good compliance on CPAP, even when my CPAP downloads are showing, you know, a good outcome, then I'll be very averse into labeling the entire EDS just on the sleep apnea.
That's exactly the point why I think, and this is for us surgeons, that giving a CPAP trial is mandatory.
Yes. So CPAP trial, I mean, if I have a person who's getting good reversal through the CPAP trial, then I can tell, you know, most of the EDS is because of the sleep apnea and not so much because of the depression. But if the person is tolerating the CPAP well, and, you know, if the psychiatrist is happy with whatever outcome that we are getting, then perhaps we can think about it. But if the person is not happy, then it's very difficult to make him happy with surgery.
So I would like quickly to take very quickly Dr. Deepankar's inputs and Dr. Nimesh's inputs after Deepankar, please.
First of all, me too. I do CPAP trial for each and every of my OSA patients, at least 1 to 3 months of trial, mandatorily, be from evidence and guideline wise, number one, and number two, from medical legal point of view, and number three, from insurance point of view also. All the major insurance giants across the globe, they don't reimburse surgery unless and until we put across some trial data. Yes, we have tried, refusal, failure, only then we are jumping upon surgery. So we should never jump upon surgery. This message is loud and clear. Number one, patient has to buy his surgery only if there is refusal or non-acceptance or non-adherence. Number two is, I am absolutely a no-touch surgeon for these OSA with depression element patients, because these are they are dangerous. They are dangerous category of patients, and I have dealt across at least a couple of patients whom I have dealt several times, and referred them to my that neuropsychiatric friend. He started CBTI and this depression and insomnia component. Patient lost to follow up, then again came back to me. He added some clonazepam or this kind of medicine, esgopiclone, zolpidem along with this CPAP. Then he recommended, Dr. Dattu, you can proceed for some why patient is not accepting CPAP. Maybe the depression is actually promoting her not to accept. And all these patients, I don't know whether there is any evidence or not. All these patients are female patients. These patients are female patients, point to be noted, and these female OSS. And then I even did DICE, couldn't find anything significant. Then again refer back to him. In the meantime, that patient turned up to physicians, tried even adaptive servoventilation, read a lot, and again turned up to me for septoplasty. Now I am in a suit because the physicians had referred back, her back to me. You need septum correction, and after did a thorough counseling and proper evaluation, maybe after 1 year, I had to do septoplasty for this particular patient with a clear written evidence and written valid informed written consent. I am doing septoplasty just to improve your CPAP compliance, and I suffered a lot. After the surgery, patient was still unhappy. So I am really absolutely reluctant to touch any depression element OSA patients, honestly.
Thank you very much for those very personal insights into this, Dipankar. Dr. Nimish, please.
Hi, so I've got 3 points to make. One is I've seen a lot of patients who have been wrongly diagnosed as depression. And once you screen them for OSA, they have positive reports, they have been treated, and they obviously get better. Secondly, there are a lot of patients who have concomitant depression and OSA, and these are the difficult ones. But the one thing that I've seen in my practice very, very frequently is that the depressive OSAs, a lot of them have concomitant PLMD, which gets missed. Unfortunately, I don't have the luxury of all patients coming to me and getting polysomnographies done. But whenever I'm in doubt, where I see that the OSA has probably been well managed, the depression has been optimized by the psychiatrist, I always look out for concomitant PLMD, because that's a very big factor into OSA and depression, which actually which helps in identifying why the EDS is not getting better. And thirdly, again, as Dr. Dipankar quite rightly mentioned, that it's very important to keep the psychiatrist and ourselves in the loop very closely, is because which is playing a bigger factor? Is it the OSA, the compliance, or the depression? Again, it's difficult to ascertain. So one anecdote which I can give you from my practice is every patient who comes to me says that, doc, okay, I'm happy to take the CPAP, but when I go on 2 days on holiday or at work, can I not take the CPAP? And my only answer to them is, if you are diabetic and hypertensive, will you leave your pills at home and go? So that's one way to give them a little bit of insight as to why compliance is very important. Now, coming to plain PAP and depression, again, it's very difficult to deal with these, but we have the advantage over here that we work very close with our psychiatrists, and any patient who we feel that compliance and or symptomatology is going to be difficult, we make one-on-one phone calls and make sure that these patients are being looked after sort of in a more gentler and more sensitive manner than our regular patients do. We also have sometimes a liaison. So one of our sleep technicians who is actually quite interested, we have used them occasionally as a liaison sleep person, where they do feedback phone calls quite often. And obviously now with AirView coming in, so patients being registered with us, we can actually go through their daily compliance also and try and help these patients out. So a little bit of, as the topic and the flavor of the day is, personalized medicine for these patients actually does wonders.
Thank you, Nimish. I think that's fantastic. The next thing that I would like to talk about is, again, anxiety. And it's, again, a very common mental health disorder. And anxiety frequently coexists with depression and PTSD. Ma'am, I would like your inputs on this particular condition.
So anxiety for sleep apnea is of multiple cause. First of all, anxiety about using the CPAP. So many of our patients, they know they type this snoring and they type awakening, and they get this OSA as an answer, and then they quickly type CPAP comes as an answer as a treatment. So they, before coming to us, they know that the treatment is CPAP. So they come already anxious that am I supposed to use this machine? Am I supposed to use this machine as long as I live?
Right.
So anxiety is when they present to us, and it starts from there. So one has to really make sure that it's just anxiety related to the disease, or it's the anxiety because of the treatment that they are supposed to. So how we introduce them to CPAP slowly and take care of their anxiety is up to us. But I've had one patient who had something mass claustrophobia, very VIP patient. Now, the only way I could really manage this patient is I made him use the mask in the daytime and for 10 minutes, just 10 minutes. So start from 10 minutes, 15 minutes, 20 minutes, half an hour. Just use the mask. Don't use anything else. Just use the mask. So many of my patients actually, they don't sleep till the CPAP is on, and they sleep after they switch off the CPAP. So once you go into their detailed history, you realize that it's not that easy to make them get convinced about using CPAP. But yes, slowly, steadily, they do get used to it, and they kind of come around and they do buy and they use it. Compliance becomes an issue then. But yes,
A
anxiety.
lot of firefighting and hand holding.
Yes.
Obesity is again a major issue. I'm not going to talk about that in detail, but this is one thing that I would like to bring about this particular point, that obesity and OSA have a bidirectional direct relationship, with each 1% change in weight resulting in a 3% change in AHI, and all of us are aware of that. Especially for us otolaryngologists, obesity poses several challenges, especially in the post-op and the peri-op and the post-op period, especially when it comes to intubations, when it comes to extubations in the post-op period. So one needs to be very careful when you manage these this particular comorbidity. Of course, this itself is it's a completely different subject, but I just want, since we're sort of touching base on each one of these, I thought I'll just bring this particular topic up. So that brings us to the cases. Subhasis, how are we doing with time?
So we are well within time. It's 8:40 right now.
Okay,
so we still have
take, yeah. These are all real patients, and this is Mr. B, who is about 40 years old with sleep-related breathing disorder, with headaches, nose blocks, sneezes, dry throat, is unable to fall asleep with retrosternal discomfort. He's not obese, he's a little overweight. On ENT exam, gross turbinate hypertrophy with septal deviations and adenoids. Obviously, the history is sort of taking us towards a situation where we may be looking at an allergy issue. His Epworth sleepiness scale was about 16. And this is the diagnostic nasal endoscopy. You can see very boggy turbinates. This is an adult man. And with huge adenoids. And this is persistent symptoms of allergic rhinitis throughout. Of course, he does have a gross septal deviation. So let me just open the sleep study. Oh, this is not the one. I'm sorry. Do you see the do you see the Word document?
It's
Yes.
visible, sir.
Yes.
Let me just. This is the sleep study. Just tell me when to stop. The sleep efficiency is about 82%, even though the guy says that he has symptoms of he's unable to sleep. Reasonable time spent in N2. Lot of hypopneas, as you can see, which is actually driving this whole thing. Okay, so I can always come back to the sleep study. So let me just so I think I would start from Rahul, especially this patient with allergies, and he claims to be having insomnia. And also there is a situation where there is positional OSA in this particular patient. And very commonly we see that in patients with allergic rhinitis and gross septal deviations. How would you like to manage this patient, Rahul?
So this patient is actually a very daily life kind of a scenario that we see.
Yeah, garden variety.
Yeah. So my first question actually would be that was the sleep study done with the kind of scopy that we are seeing now, with those active allergies in place, with this nose block in place? Because that is a very different picture.
No, not really. That is a good question, Ram. This is in the pre-op. This is in the outpatient. By the time this guy got the appointment for the sleep study, it's been a week.
Right.
So yeah,
just a point for everybody who's participating here and watching the Zoom. Don't be in a rush to perform a sleep study if there are acute rhinitis, acute issues happening, and please counsel the patient well, especially if you are doing it in a home sleep study setting. So that is one. And I think this patient also has, there is obviously allergic rhinitis, there is a lot of adenoid hypertrophy there, septal deviation, but from the symptoms, I feel there is a significant component of LPRD also. There could be a lot of reflux happening given his BMI of 34.
29, yeah.
So working on the allergy part, working on a lot of lifestyle changes, talking to him about, optimizing his diet routine to take care of the LPRD, keeping that 3-hour gap between meal and sleep time, and those things will definitely help. He's got significant desaturations from what I could gather from the oximetry study. Now I will talk to this guy in terms of getting at least a CPAP trial done after he is reasonably medically optimized. Again, the sinus part will play a major role, and I'll be a little aggressive in prescribing him twice a day antihistaminics with nasal sprays, and then talk to him about that. Yes, I think CPAP will be required because the oximetry data is such. At least a trial and see how much of his daytime symptoms reverse with that. Weight loss needs to be aggressive. Seeing how the patient responds to it, if he's tolerating the CPAP well and I'm medically be able to control and the pressures are not so bad, that makes my life simple. Unfortunately, I don't expect a very good CPAP compliance in this patient. So if he is not tolerating the CPAP well and he requires a very high pressures, and I'm getting suboptimal relief from my medical therapy, more so in terms of the nasal obstruction, then I can consider this patient to, for the nasal surgery, but that will be like at least a month and a half down the line. Once I've tried all the medical therapy and the patient is really compliant, because this guy has not reached his current weight by being very health conscious. So that compliance will be an issue with him. I mean, the follow-up practically might be an issue. And then perhaps we can consider, nasal surgery to optimize CPAP usage till he loses weight. And parallelly, we can start him on myofunctional therapy for whatever benefit that may provide to him, along with LPRT control.
So my question again would be, and I'll definitely go to Dr. Goti and Dr. Shah about this. Would you actually offer him PAP therapy, especially when we know that he's got POSA and on the lateral position, he has hardly any apneas? That too, that is point number one. Point number two, do you think just medical managing his allergies would sort of reduce his symptomatology, especially because we know that allergies and insomnia again are comorbid? What are your thoughts, Rahul?
I think so. I feel, sir, because the oximetry data was significant actually.
Right.
So, I would at least offer him a CPAP trial once the allergies are controlled, and if he's able to tolerate it and that is helping, I mean, POSA would be helpful, but I'm not so sure whether, because his oximetry data was really bad. So just pure POSA would help us get out. And if he's tolerating and if he's getting relief, then that's great. But I mean, it has to be a stepwise fashion. Once control the allergies well, and then if there are persistent symptoms, then CPAP trial. If he is able to tolerate, then my job is done, which I find little less likely given his, adenoid size, especially. And then work aggressively on the weight loss and see how the patient is doing, and then be a little reluctant. But, I like to see some weight loss happening before embarking on surgery.
Let him earn his treatment.
Exactly, something like that. After a couple of months, and then plan for a nasal surgery.
Let's hear it from a different perspective. I think first I would ask Dr. Goti and then Dr. Shah as well. Ma'am, how would you manage these guys?
So
this patient?
I would actually agree with Dr. Rahul. What he said is absolutely right. One needs to treat nasal allergies for sure. Some of the hypertrophy could possibly subside with nasal steroid and stuff like that. In children, especially, you have Ghazale al had done quite a few studies wherein, in children, they treated only with nasal steroid and they improved mild to moderate sleep apneas. In adults also, mild sleep apnea, you can think of giving. Plus, he is a little overweight. So yes, I think I would go by what he is saying. He has a little bit of, what do you call it as REM sleep hangover maybe.
Right.
Possibly,
yes.
It's a rebound REM sleep.
Yes, there is a REM rebound, there's REM predominant events are there, ma'am.
Yeah. So that's one thing possibly that, with all this, maybe you can, and one needs to talk to the patient all the time. You need to see the pulse of the patient. You need to find out what he wishes or she wishes, and then go ahead with the treatment rather than simply embarking on CPAP therapy right away. If he says, yes, I can't lose weight. If he says, yes, I'm otherwise well controlled, then you go by the pulse of the therapy. Positional therapy per se, not, a very, very big fan, because those who are sleep apneic in supine position, they do well with even CPAP therapy. So, yes.
Especially when I would like to probably ask Dr. Shah now, your thoughts on this as to, and specifically, what kind of medication would you choose? Because especially this guy has REM, more events in REM. It's probably, and according to guidelines, if this patient is not responding to intranasal corticosteroids, what is your threshold to put him on antihistamines?
So, especially in this case, I would first like to ascertain whether his symptomatology is more because of his comorbids or because of the sleep apnea. Because if you technically go by the score, it's only a 12, which falls into the mild category.
Correct.
So I personally feel, looking through the history, I think it's all his comorbs which is actually causing more of the EDS, because he's getting poor quality sleep because of that. there's no denying of the fact that he needs the OSA and the hypopneas addressed. In terms of antihistamines, we all know that it hampers your hypnogram, but I think topical azelastine actually works very well for these patients with very little systemic side effects. So a combination of fluticasone with azelastine, the combination nasal spray works very well, and I would use that as a first choice, and then use nocturnal antihistamines, because obviously giving him antihistamines in the daytime would again lead to further EDS. So I would use the azelastine combination spray to begin with, and then give him systemic antihistamines at nighttime.
So when will your threshold be to send the patient across for a surgical intervention? Because I've heard from Rahul and I would like to hear from you. When would you send him for surgery? So
in this gentleman's case, definitely let him earn his let him earn his treatment first. So definitely give him a trial of weight loss. Secondly, he's a 50-50 candidate where you would consider DICE, because when you know that he may not tolerate CPAP therapy because of his comorbs, then probably DICE may help us in the evaluation. But I would then hint more towards surgery first as opposed to PAP therapy, simply because we've seen the adenoids. We know that there is an anatomical problem. I would address that first rather than put these patients on PAP therapy, because again, compliance will be an issue with him in the long run.
Perfect. I think beautifully summed up, Raksha. Thank you. So then we'll go to the next case. This is Mr. V, who's a 35-year-old software professional with classical snoring and EDS. He's also hypertensive, and this is where I need Dr. Vijay's inputs as well. ESS is about 18.
Sir, sorry to interrupt. You just need to share your screen, sir.
Oh, okay. Okay, thank you. Yeah, are you able to see it now?
Yes, sir.
Case 2?
Yeah.
Yeah, visible, sir.
So he's a 35-year-old software professional with snoring and EDS and hypertension. BMI 26, Malampati, normally because even though we use the Friedman, I think because it's a multispeciality meeting, I'm using modified Malampati, grade 1. He has grade 4 tonsils and lingual tonsils. This is the FLP finding. Are you able to see the video?
Yeah.
Yes.
This is the view from the nasopharynx. This is obviously the tonsils. Let me now go back to the PSG report. Are you guys seeing the report? No, right?
No.
You can't.
Yes. Are you seeing it now?
Yes.
So I'm going to now scroll it a little bit. Please tell me to stop if I'm very fast. I'm going to stop sharing now. And let me just... Okay, and this patient, of course, this is a DICE video of this particular patient. This is an intraoral DICE. This is the tongue, this is the tonsil, this is the uvula. So,
So you are on mute.
could you hear me now? Can you hear me now?
Yes, sir. Yes, yes. We lost you for a while.
Did you? Yeah, I just got disconnected. Did you see the video?
Yes.
Yeah.
Yes, absolutely. We saw the video.
All right. So I think we'll start off from, I'll ask Dr. Vijay from his, so such a patient, right, Dr. Vijay, with hypertension, reasonably young guy, how would you manage this patient? Did you see the PSG report?
Yes, sir. Yes.
Yeah. So how would you go about managing such patients?
Sir, yeah. So regarding this patients with hypertension and this associated OSA, we have certain kind of clues to pick up from our clinical evaluation that probably OSA could be the secondary cause for the hypertension. One of the things is that if we are unable to control with multiple drugs, so which we call it as resistant or refractory hypertension. The other thing that we look at is if there is a discordance between the hypertension, the clinical blood pressure, and the evidence of end organ damage on the ECG or echo. If we don't find LVH or anything, and if the patient has clinically high BP, then that is a cause, there is a reason to suspect. And one more important thing or a pattern observation that we come across is when we do a 24-hour ambulatory BP monitoring on such patients. So there is a pattern where we encounter frequently, that is in normal patients, there is something called as the nocturnal dipping. So where the BP dips, and if we find a non-dipping pattern, or if we find some nocturnal surges in the blood pressure, then probably these are the patients given a background of high BMI, as well as evidence of an obstructive component to the sleep apnea. So we will probably associate this hypertension to the OSA, and we'll have a very kind of low threshold for treating OSA in these patients.
Thank you. I think that sums it up in a nutshell. Thank you. I think it's a very obvious kind of a case, but I would like to use these last few minutes that we have to I want to hear from each one of you as to what you think of MFT, and it's making huge waves in literature, and all of us have basically started using MFT. And I'll start from Dr. Goti. Ma'am, what do you think of MFT? Are you using it in your practice?
So MFT per se, as a myofunctional therapy, what you call it as,
Yes.
it's been reported as a treatment, as an alternative treatment. However, the efficacy is not proven so much, especially in this patient who's still obese, who definitely has a kissing tonsil seen on the both the DICE and both on the laryngoscopy. So in this patient per se, I would not really go in for this MFT kind of a thing. Yes, to an extent it does help. It does help in strengthening the muscle. It does help in improving the tone of the muscle and stuff like that. But definitely not in this case. This case does need weight management, does need surgery for kissing tonsil, because in adult, if you have he typically doesn't have a very he's not very obese. If the patient is not very obese and he has such a large tonsil, first thing is first. So one has to get the tonsil out and then see whatever residual sleep apnea is there, and then go on the next phase of treatment. So
perfect. I think would you, Dr. Shah, would you do anything different?
No, I think I probably agree with Dr. Goti. The only thing is MFT probably has a role in patients who have mild OSA or mild to moderate with a high BMI, because if you don't want to put them on PAP therapy along with a weight loss program, you can try MFT, and I think the combination of that may actually serve us better.
Especially, I think in the pediatric population, it's huge. Dr. Datta?
Yeah.
Your take on MFT.
I do use oral myofunctional therapy for my patients, but not
my
as a
question is
not as a standalone.
Yeah.
Not as a standalone therapy.
Yeah, that would be my question.
Yes,
so,
never as a standalone therapy, as an adjunct with the mainstream therapy.
Perfect. I think that sums it up. So I think we've sort of covered as much as we could in the time that is given to us. Let me again thank each one of you on the panel from the bottom of my heart. And a special thanks to ResMed for allowing us to have this wonderful discussion and have this sharing of ideas. And I have surely learned a lot from this particular webinar. Thank you. Thank you very much.
I would like to thank you too for involving us. It was actually very good and interesting. Thank you.